Hello, my name is McCall Christopher. I am a doctoral in athletic training student at Indiana State University, and today I'm going to talk about the evaluation of lower leg, ankle, and foot injuries and reflect on how I do evaluations, what I do, and some improvements I could make, and just a reflection on that. So some expectations you can find for this presentation is that there are plenty of different ways to evaluate the lower leg, ankle, and foot, and any injuries that happen. We're assuming today that in this evaluation, or as I go through this evaluation, that it's a non-emergent situation, so you're not on field, it's more of somebody walking into a clinic, and that you can need to focus on more than just the actual injury, what's going on above and below the joint that is in question. So, where I start, when I have somebody walking into the clinic, I assess how they walk into the clinic, whether they're hunched over, whether they're limping, and then how they approach you for help. Is it in some situations you're approaching them, hey, how can I help you? But sometimes they're asking for an eval. Also looking for any bracing, wrapping, or possible crutches that they might be using. That's all going through my head as I'm evaluating the situation. And also some facial expressions they might be able, um, or they're providing as a little bit of feedback on how they're feeling as they get on the table or walk across the room. And then just generally how they carry themselves. Do they seem down? Do they seem upbeat? Next, I kind of assessed through a history. I asked what happened, when did it happen, where were they when it happened, or what were they doing, playing a sport, were they, at home, fall down the stairs, that sort of thing. Can they pinpoint one spot where it hurts and what kind of pain it is, and has it happened before if they have previous injury. At that point, that's when you would assess for an immediate action or referral. If it seems something more emergent, they're having more of a whole limb problem, um, something like obvious deformity, obvious fracture. You would not spend time evaluating. You would refer, or you'd appropriately take action. Some observations I take next would be swelling, bruising, and any deformities, whether it's some kind of step off, or um, whether you can obviously see like gross swelling and ecchymosis in their joint or their lower leg, also into their foot. I take all of these observations into consideration next. Then I focus on palpating. So I start away from the area that they've pinpointed pain and I work inward. For lower leg, ankle, foot, I always utilize the Ottawa ankle rules, maybe focusing on one area of the Ottawa ankle rules, depending on the description of their injury. And then while I'm palpating and through all of these different um, bony ligament or bony landmarks, I'm just kind of assessing for sensation and pain. So kind of getting their dermatomes while we're going through this, and, palpating the different areas, and even maybe palpating bilaterally to make sure that if there is a slight deformity, that it's not something they already have naturally. Next, I look at range of motion. So first I have them actively perform range of motion on their own. I ask them what they can do so we can kind of assess their baseline before I start moving them, and then what motions are painful. So whether it's at the ankle or the lower leg involving the knee, individual toes, I'll assess all of the possible range of motions there. And then passive range of motion. So once I've decided what is most painful and what their active range of motion is, I might provide some overpressure. And I keep in mind those motions with pain, and obviously be more gentle with those movements. And then always bilateral for this, so I'll have them slide both shoes off when evaluating so that I can assess both sides and compare. Next, I do manual muscle testing. I test the ranges that are possible. Sometimes they don't have any motion, so you wouldn't obviously manual muscle test there. And with this, bilateral testing is absolutely appropriate. Then I'll do some joint mobilization. So I'll do some. These can be considered. They can be considered special tests, but I like to classify them as joint mobilizations. So I'll do like a metatarsal glides, just assessing for the movement. If there's swelling there and there's a lot of pain, you might not do that. I do movement of the fifth metatarsal head, and then fibular head movement for associated usually with ankle issues. And then I also do talocrural and subtalar AP and PA mobilizations if they can stand it, and then distraction of the joint if they might be a little apprehensive, but this could also just relieve some pressure that's going on in that joint. Then some common special tests. So I'll move on then after that. Obviously, drawers have already been done, but I'll maybe use tuning fork for something that suspected fractures, squeeze bump, those kind of rule out the major issues. And then obviously appropriate special tests will be broken out into individually after that, whether it is Morton's neuroma with the pencil test or other individual foot tests and lower extremity tests. And then the major thing I do after this is with patients that are mobile and aren't limping and are able to do a gait analysis, I start there. I have them walk, focusing on collapsing arches or movement in the ankles and knees and hips bilaterally, seeing where the deficiency is happening. And then I also focus on their foot postures. Do they have flat feet? Are their arches high? Naturally, is there a discrepancy bilaterally? And then also knee and hip alignment can definitely play a role in this, whether they're anterior rotated just in the standing position in the hips, or if they have knees that are a bit valgus. Those are all assessed. Next, I educate. I think it's so important to educate your patients on what you're finding as you go. Maybe not go through all the differentials with them, but definitely talk to them about what is sticking out in your mind, and then assessing and talking with them about management and future treatments. What are they going to be looking at? I always go a little longer. I'll say this might keep you out for 2 weeks if I think it might be a week or week and a half, just so that they're prepared. And I always talk with them on what they can be doing, whether it's medication or different at-home exercises, and then how this affects their participation in sport. Specifically for me, I'm in the college setting, so that's usually the first question that we talk about. So after reflecting on my total evaluation, some gaps that I found in what I was doing was I think I could definitely implement patient-rated outcomes more often in this initial eval. I have yet to find comfortability in this because it's usually a quick eval, but that is definitely something I'm looking to improve on. Functional testing, I feel like I don't do very much of that and could incorporate that in certain situations. I also feel like I'm less streamlined in my evaluation and I go step by step. And I think that's just something we all can improve on, and I'll get better with experience. More specific special tests might help and improve on my general evaluation. I do feel like the ankle, lower leg, foot is a less complex as compared to maybe some shoulder special tests that you might need to utilize more. And I just feel like I need a more comprehensive evaluation of hips in the whole person. I think I lack in really looking at back or even some core and upper extremity issues that might be affecting their lower extremity. So these are some goals that I'm looking to improve on as I go and throughout the course, especially in this class. Thank you, and please let me know if you have any questions.